Hey, Fix listeners. I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So, if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy.
And you're listening to the Fix Podcast,
your source for all things implant dentistry.
What other courses have you heard that you really like? What, as a general dentist, how many courses, like before you do your first full arch, how many implants should you place? And I know that that's super controversial, but I'm just curious your thoughts on it, right? And then I'm curious, once you get into full arch, right? I feel like there's a lot of different modalities on it, and every oral surgeon that I've talked to about general dentists going into full arch, their biggest concern and biggest issue is, hey, if you can fix your problems, then I think you're good to go to do full arch. So going off of that, then when does somebody who's doing typical standard all-on-4 start getting into advanced PATSI or, like advanced zygomatic pterygoid implants? What do you think is like suitable as far as those things go?
Okay. I don't want to be, the gatekeeper, the authority behind this, and I'm not. I'm teaching to try to help people into it. There is no number. Everyone's like, how many implants do I have to do? 250? Is it 1,000? I don't know. What is your comfort level? You should be comfortable doing this, and you should kind of know how to get in and out of complications and problems, like, so you can avoid them. We all have to start somewhere. I definitely don't think that you should be doing your very first implant ever in a full arch. I think that's absurd. I think we heard that 6 months ago. People come from different backgrounds. If you're previously a farmer or a woodworker, and then you come into dentistry, I mean, you got some, and then you're really good at the science and the biology of it. I think, you've got really good hand skills. You've got good mental capacity for problem solving, probably sooner, right? I don't know. If you grew up inside of a textbook and never getting out and seeing the light of day, and then you think you're going to get thrust into a full arch real world situation, I mean, I don't know. So, like, what's your life skills? What's your background? And then I think, in my opinion, you should be prepared to move quickly after standard full arch, because I hate cantilevers and I hate short AP spread.
Yeah.
And the simple fact of the matter is, and I've looked at this in my own patient population, in your standard maxillary arch, your average maxillary arch, it is difficult to put the platform of your tilt much further than the first bicuspid.
Mm-hmm.
Okay. And sometimes it's between the canine and the first bicuspid. That gives you a 2.5 tooth cantilever. In thin bone, soft bone, shorter implants, less spatial bone anchorage, you name it, you get an AP spread of not even 10, 12 millimeters at the most in 80, 90% of your arches. So to say that, I'm going to do a simple maxillary arch, I mean, I'm like, I think I saw 1 out of 350 last year, like, you don't get simple maxillary arches. And a simple maxillary arch would be like, maybe I've got a second premolar and a 1-tooth cantilever.
Yeah.
Right. That only happens like 4% of the time. So you've got to be prepared, to go and do a pterygoid or a zygomatic or do a shorter bridge. You also have to be prepared to do an FP1. Knife Sonata was just here. We just did an FP1 course with Dr. Sonata.
Awesome.
Yeah.
And shout out to him. We had a great weekend. He and I went skydiving on Sunday. We jumped out of a plane 13,700 feet.
Hell yeah.
It was amazing. And he's coming back in May. I think we haven't picked the first or second weekend yet, but that guy is so brilliant, and he's probably one of the most even-keeled, level-headed humans on the planet. I love talking to him. He's so philosophical and deep. But like he said, everyone, I'm going to steal this from my buddy, my friend. Everybody's racing to learn zygomatics, and more people should be racing to learn FP1 because truthfully, we're going to see more of those cases.
Yeah,
Mhm.
you're right. Yeah.
For sure. I see so much. I see it everywhere now. FP1. I see, 5 years ago, everyone that came into my practice was 65. All of a sudden, I'm getting all these 30-year-olds with recovering alcohol, drug habits. Just sugar, never cared for their teeth. They don't have a disease of the bone; they have a disease of the teeth.
Right.
So I'm getting very long-winded here, but I think when you jump into full arch, you should be prepared to go all in. That's kind of one of the reasons the name of my podcast.
That's good. Yeah.
You gotta be like, okay, I'm gonna get to the standard course, and then soon I'm gonna take the remote, and soon I'm gonna take the FP1, because you can't treat 100% of your maxillas unless you know all three.
Yeah.
So,
Mhm.
and I'll turn it over here in a second, but that's why we do the education with the continuum 1, 2, 3 and 3 is remote anchorage, and then we do the FP1 with knife, and then if you take all 4, you should have the whole
Yeah.
scope of the project.
And I really agree with this too. And I think that, the fallacy here is the idea that you're going to get into simple all in 4, and then you're going to get all your reps there, and then you're going to go into more complex stuff. I think really the starting platform needs to be before you're doing your first all in 4. Like, you need to show that you have the didactic information. You at least understand what complications look like and what their solutions are, and show the surgical efficacy with much simpler and, with the types of cases that aren't going to blow up on you and like ruin someone's life, right? Like a single implant, like a single immediate. Like if you can place a beautiful single immediate implant in number 9, and you have beautiful soft tissue and all the hard and soft tissue is great, you are a very competent clinician, right? And then you can get an all in 4, and then you can do everything after that, like pretty easily, because you've already got the hand skills, you've already got the knowledge. Like you should be off the block really fast. And I've seen so many clinicians that have really eclipsed me in terms of my growth, because I kind of grew through the context of all in 4 personally. I was like very right off the block, like right out of school, and I grew through all in 4. But the people that did all that research beforehand, and they did a whole bunch of thirds, and they were really good surgically, just didn't really have the reps all in 4. I've seen them go from just doing their first all in 4 to doing pterygoids to doing transsinus in no time, and they did it beautifully and did exemplary cases. And so it's not about getting the reps of basic all in 4. It's about having all the foundational stuff first, and you can tell a lot about how good someone's going to be before they ever even do their first one. So I think that's where the focus needs to be. And I totally agree. As soon as you get into the all in 4 world, you got to start getting into complex stuff immediately, because you're going to make your own complex cases, when
for
doing
sure.
them wrong.
I have
Two
a
things-
slide in my. Oh, sorry. Go ahead.
Oh yeah. I didn't mean to cut you off. I was just gonna say 2 things that I really agreed with, and actually I mentioned this on our last podcast. We had just, I think maybe like 4 weeks ago, we went to the 3-on-6 guys course, and we've been doing one prior to that. We just wanted to see. I don't know if you've had like those patients come into your door that are like 3-on-6 or nothing type of patients, but we've started to see them because they're developing like a following online, right?
It's a cult following, yeah.
Nothing. And in reality, like we spoke to the guys about this, right? It's basically just standard FP1 that they segment, because in their philosophy, Wolf's principle is where if an implant doesn't get a full load, it won't have like the same potential as one that's splinted. Essentially, that's kind of like their philosophy. But anyways, we did a podcast with them, and in the podcast, I said a very similar thing that you said. That I think that if you're going up the progression, standard all in 4, like easy cases that aren't super difficult, like good bone thickness, whatever it may be. But if you can get 4 implants, you can get to that second pre or that first molar. Like those are awesome cases to get started with. And then I think incorporating in pterygoid implants is a next good level up, because you are reducing that cantilever. You're providing. I'd rather have a patient in a pterygoid than one that's stuck with a 2-3 tooth cantilever, right? So that's
right.
And then I personally like going FP1 next, because you're saving a lot of that bone, right? Like you're saving a lot of those patients that have difficult cases. And then after that, like if you want to get into zygomatic, transnasal, all of these different styles, to then fix all those ones that you've done prior to get treatment.
Yeah.
And then the second thing I want to mention is I totally agree with you about people's backgrounds, right? People come from all different backgrounds. For me personally, I did a 1 year surgical internship where I worked under multiple surgeons for a year, and I got so much good quality
Yeah.
basic experience that then when I jumped into implants, I was like, man, I already know all the hard stuff, right? I know how to lay big flaps. I can see all of the bone. I can take out teeth efficiently. Then placing the implant, is the easy part. But
Right.
where I see issues, right, is where doctors they don't reflect a full flap, right? They reflect a very tiny flap, and then they go in and they do this after it took them 2 hours to take all the teeth out, right? So that
Yeah.
takes them 2 hours to dentulate the arch. Then they don't make a good flap. Then they're trying to stick the implants into something that they can't see, and it's like, man, you obviously didn't get the proper basic surgical knowledge to then go into the all on four. So that's where, I think that if you get good at surgery, you get good at edentulating, you get good at laying flaps, then the full arch part could be easy for you.
Yeah. I have a slide, and I want to talk about the 3-on-6, or the all on, what do they call it? The 3-on whatever.
3-on-6, yeah.
Yeah, thanks. Yeah.
3-on-6. Yeah. But I have a slide in my intro class, and just as we get into the introduction about when are you ready,
Mhm.
and all on 4, all on X, full arch, fixed immediate load, full arch is just a combination of a lot of skills, and you have to be able to do it expediently and efficiently for the patient. And so it's like you mentioned anterior immediate load. Can I do a single anterior immediate load?
Mm.
Huge.
Yeah.
Can I do a full arch of extractions in an immediate denture?
Mhm.
That's like paramount, right? Can I surgically extract teeth? Can I extract third molars? Right?
Yeah.
Sinuses. Can I do a sinus lift?
Mhm.
Okay, that's huge. You need to know in and around a sinus, you're going to be in there. You're going to be in the sinus.
Yeah.
100% sure. Can I do an overdenture? Do I know occlusion? I have so many patients. I have so many doctors that contact me and say, I'm new to dentistry. I want to do fixed all on X because I hate dentures. I can't do a denture. I'm like, you need to do a denture before you can do this. You have to be able to understand prosthetics, full
Yeah.
arch occlusion before you do this. Like, it's essential. Go make some dentures. Go work in a denture clinic for like a year. It's so essential that you be able to have all these little tiny subsets of skills to do this. And so it's like, get the training. I had a doctor come here for a one-on-one. He wanted to do a surgery, and I was watching him like try to extract a tooth. He's turning the gums into hamburger. He doesn't know how to section it. I'm like, whoa, sport, like time out.
Sport.
Like we got like step aside for just a quick second. Like it's been like you got 2 minutes to get this tooth out. Like we got to
Yeah.
go.
Yeah.
Like
Yeah.
we've got like 27 more to take out. Let's spend 20
Yes.
minutes on this tooth. Come on.
Yeah.
So you've got that. I was going to comment about the
The 3-on-6.
3-on-6 or whatever. So great guy, great program. They've done an excellent job marketing that.
Incredible.
I think the
Yeah.
public knows about it. All the way in here in Virginia, I'll have people in consults go, "Hey, should I do all on 4 or should I do on 3-on-6?" I'm like,
Yep.
okay, look, there's way more similarities than you think. This is a marketing scheme. It's a marketing ploy. I had a conversation, nice guy. I'd love to have him on the pod. And I think that he makes some kind of claim of inventing it, or trademarking it or something. I mean, the fact is, when I came here to practice with Truman Baxter in Virginia Beach, Virginia in 2006, Truman was doing them already. I mean, we saw people, they talked about doing these things back in the 80s, and the reason they did them was for retrievability. So
Mhm.
I've done the 3-on-6 procedure a whole lot of times, and he was like, really, show me extra. I'm like, I'm not going to go dig up paper charts, but we used to do like 2 implants, 2 implants, 2 implants, and do 3 just in case something failed or
Yeah.
needed to be replaced. It wasn't all on one arch. So that was kind of something that was common. I think it's a great procedure. I think it should be done. It's very much akin to an FP1. I mean, it basically is an FP1 in 3 segments. So I've got nothing against it. I think it's a great treatment modality. But the bottom line is you got to be prepared to do FP1.
Yeah.
Yeah.
No, I couldn't
100%.
agree more. Couldn't agree more. And I think too is, to kind of go a little bit back to, our conversation on, digital dentistry and the digital world and all the people that are now coming out into a world that is fully digital and has fully embraced that, is that so we've abdicated so much of the fundamentals to labs, right? Like when
Right.
you send your stage 0 records to a lab, all you really need to do is you take a scan of the upper, scan the lower, take a bite, take some photos, and a really competent designer can make some beautiful stuff happen, and you'll have no damn idea what they did. And I think it's a good thing, but there's another side of that where you can skip a lot of the fundamentals and still be doing these cases. But where you're going to get in trouble is that's a blind spot for you. You don't actually know what the lab's doing. The lab does kind of know what they're doing, but they're not actually in your practice. They're not really taking care of this patient. They're not really seeing the functional issues going on. They're just making the best of what they can with what you're sending them,
Yeah.
And so without that sort of foundational, like this was in my hands, or I had this in an articulator, I saw this patient, I understand occlusion, I understand dental principles. We're kind of flying by the seat of our pants, and we're abdicating a lot of the actual doctor job to laboratory technicians, and eventually it will be AI as well. But it's this is kind of a trend going on in a lot of industries, is as AI and as digital becomes more prevalent, we're kind of losing a lot of the foundational skills there. And I think that we're going to become less complete clinicians out of that.
Yeah.
Yeah, I
Really
think
careful. So module 2, module
no,
2, I
you
talk about prosthetics occlusion a lot
Yeah.
in our
Yeah.
module 2 digital workflow class. And labs we put too much trust in labs.
Yeah.
Okay. I mean, they're hardworking individuals, they're smart people, but
Agree.
they're not doctors, and we forget that. And a lot of dentists, I don't even think are thinking like a doctor.
Yeah.
You have to diagnose the occlusion. You have to set it up. Don't just scan it, get it to the lab, get it back, and then just screw it in. I guarantee you, if you're objective of your prosthetic, you're probably going to see 10 mistakes made that could be better easily.
Yeah.
And you've got to constantly like retrain your lab. And I go through this. I know this because I have an in-office lab, and I was my own lab tech for a while. So now I kind of know how they think as I train new
Mhm.
lab techs. Put way too much trust in labs. I mean, I did I was going to do a stackable guide course, and I got a major national stackable guide company to come in here and do a case with me, and they were, the expert.
Yeah.
They said, okay, we got your plan ready to go. Your implants are there. And I'm like, let me see them. They're like, don't worry about it. We got the best technician on the job. She's been with us for 12 or 15 years, making
Yeah.
stackable guides. And I'm like, I want to see, let's go in, let's look at these implants. I started talking to that 12, 15-year technician who does this exclusively. And I had to explain proper implant position, basal bone, palatal walls, lingual walls, angles, forces, why we use this, that, not that. And, she was very much like, hey, she was interested. She's like, nobody's ever told me this, and this is the person that 15 years offices around America and the world have been trusting to place their implants for them.
Yeah. Yeah.
My message is
scary, right?
be a doctor, like
Yeah.
know the craft and
Yeah.
like look at it.
So
Yeah.
I just did it's funny that you say that, because I just did a course, and I just kind of wanted to brush up on implantitis, new age treatments. Like if anything has come out recently that is improved. And so I did a whole course, and a lot of the lectures were based on it was like some World Congress of Implants, where they did just a lot of periodontists come in and they go over the new and improvements, right? And it was funny because a couple of the lectures were about preventing, right? And it was about like, what things can you do prior to your implant placement to ensure that it doesn't have these issues. And the number one cause of implantitis was surgical placement. And it was ensuring that you have proper buccal width, ensuring that you have like all of these super basics, right? And then you go and you look at some people's cases, and they're like, just like you said, there's a lot of doctors out there that is just like, I see bone, I place.
Yeah.
and there's just so many, if you just really have to think about these principles to avoid, you don't want over compression of the buccal plate. You want to make sure that, and don't get me wrong, I understand that there are cases out there where you have to you can't always do a perfect implant placement every single time. But there's a lot of cases out there that I see where I'm like, man, you could have placed that implant a hell of a lot better. And that patient probably isn't going to be back in your chair in 5 years with all their buccal threads exposed. So like you said, like, I agree that if you're doing guided cases, I think it's important that you review the placements prior to going in there and just getting it done, because it can be the difference from you doing a revision surgery in the future.
For sure. Yeah, for sure.
And then,
And our fundamentals course talks about the best anchorage points for implants. And so oftentimes I see stuff on Instagram and the doctor has completely missed all of the anchorage points. Like all of the basal bone is missed. I mean, I just saw a post last week where a doctor said, the GP, I think, posted and he said the surgeon got excellent torque, 30 to 40 in all of the sites.
Wow.
the lowest that you should get to load.
Yeah. Wow.
And I was like, I commented, I still haven't gone back and seen if there was a reply on it, but I was like, hey, if you're not getting like 60 to 100 newtons on 90% of your implants, like DM me, like call me, like like it's like they should be tight. It just blows my mind, what's out there. People just trust, by the way, the surgeons. And a lot of surgeons are my friends. Surgeons are going to watch this. Love you guys, everybody. But just being a surgeon doesn't make you an authority on implants.
No.
Okay. I mean, case in point, like Study Club last night, smart, brilliant surgeon talking about how he pulls arrows out of eyes and, saw blades out of heads and stuff. That doesn't make you a good implant dentist. Okay.
Yeah.
The title of the presentation was the zero bone loss concept. And I'm like, okay, I'm going to take a night off my life. I want to go hear someone talk about the zero bone loss concept because I believe in that. And I want to hear what other people's take is on that. There was nothing in this lecture that was zero bone loss concept. Okay. I mean, the implants were crestal. They weren't subcrestal. He talked about having 2 millimeters of keratinized tissue. The rule is 3, by the way. Didn't say anything about the buccal plate. Didn't say anything about subcrestal. The third rule is eliminating the micro gap and having ideally a Morse taper implant. The company he was speaking for does not have a Morse taper implant. Like, of the top 5 principles of of zero bone loss concept, nothing in the lecture was zero bone loss concept. Nothing. Zero. And yet I look around the room and there's like 50 people. I didn't say anything because it wasn't my show. I mean, they had referral docs in there and everything. I wasn't going to rain on the parade. But like, there was like 40, 50 docs in there that are like, this guy is the authority on implants. And I'm like, it's not always true, just because you have a title or you've been in the game for 35 years, it's not always true.
Yeah, I agree with that. I mean, Tyler and I, we have had probably, almost every single top doctor on the podcast. And I'll tell you that one thing that between all of them is the ones you can tell that are super, super good at what they do are the ones that are continuously learning, right? They're just like, that's their thing. We just had Zelig on the show. And I think of Zelig as, he is a beast. He does stuff that I am like, man, that is impressive. I don't know if you guys just saw, did you guys just see the one where he took the whole, like,
Yeah.
And I was like, I would not have touched that. Anyways, but he came into our podcast with just so much like spark and so much light. And about how he is constantly learning. And I mean, I guess I'm not trying to say that there aren't implant authority figures, but what I do want to say is that, before you step on stage and lecture to a bunch of people, make sure you have your facts straight, right? And make sure that that what you're talking about, if somebody rebuttals it, you can have an answer for that, because there are people out there that are much further along that aren't up on that stage. And maybe that's because they think they're constantly learning.
Yeah. Oh, I mean, I'll go to any lecture. I want to hear what other people have to say. But throwing in that buzzword, zero bone loss concept, to get people to show up and then not talking about it's like the same thing as we have photogrammetry, but you don't have photogrammetry. Like the word doesn't define what you're doing just because you use the word. So it's like everyone just maybe go learn from a lot of people. You can't just trust one source, but go learn from a lot of people, because there's a lot of I hate the term on Meta, misinformation. That's just kind of my skin crawls when they say misinformation. But there's a lot of misinformation out there, in the lecture circuit and on
You bet.
stage. You know, I mean, I've seen it in main podiums with like 1,500 dentists in the audience, and someone's up there talking about something that's just total bullshit. Like,
Yeah.
no, you can't just like tunnel and like shove a bunch of particulate over the ridge. I literally saw this one time. We're gonna cut, we're gonna tunnel, we're just gonna shove a bunch of particulate on the posterior mandible and come back in 6 months. And I do implants like this, and it works every single time. Like, I'm like, there are 1,500 doctors in here listening to this BS. Like, stop. You're like, stop, time
Yeah.
out. Like, no, that doesn't work. You're gonna get people in trouble.
Yeah. Right. Right. Yeah, no, I totally understand. And we've experienced that too. Like we've been to some, I won't drop names, but we've been to some like pretty big, conferences that attract people from all over the world, and seeing some of the things that get talked about. And it's like, man, I don't really know that I don't see how this is reflected in reality. Like I don't really see how what
Yeah.
you're saying could actually be true. It's not innovative. It's nothing, spectacular, but you can make a very convincing slideshow and convince people that what you're doing is just, God's gift to earth. But yeah, I mean, it's funny, the disconnect from like the lecture circuit and what actually
Yeah.
works in reality.
Yeah.
I will say that a lot of times when you see that, right, I typically rarely see a 1 5 year follow up on those type of things. Sure, you could stick a bunch of aloe xeno mix in an area and it's going to look pretty on the X-ray on the day of surgery.
Yeah.
But what does that look like for 4 years from now? Even like things can look good at the year mark, but it's like ensuring that you have proper follow up before you're posting that stuff, because guess what? There's going to be, if 1,500 doctors are in there, there's going to be a quarter of them at least that go back to their office and they give that a shot. And who knows what's going to.
Yeah.
Especially if you
It's all
bill it as
very-
being easy.
Yeah.
Everyone's gonna do it on Monday if you say it's easy. Like, oh, 1 incision and 2 stitches. Okay.
Yeah, no problem.
For sure.
You know,
Yeah.
the
Yeah.
mini implant king, like the mini guy.
Yeah, I think that's really one of the biggest issues in implant dentistry in general, is that we can celebrate really early, right? Any arch you do, it's going to screw in, just fine, right? Like we are so far removed from the consequences of what we do on a daily basis because it's so far in the future. It's out of sight, out of mind. And when you're willing to think on a very short term basis, you can think that you're just 1,000% successful just all the time. You're batting 1,000. But the reality is that's just not how it works out over time. And it's a lesson that gets learned probably way too late. You've created way more problems than you actually have the capacity to solve by the time they come around. And I think that's the most insidious aspect of what full arch is. It's just, it's so easy to get way in over your head, and you won't actually know it until you're pretty much buried.
I agree. Well, that's why
So
we want to reach out. Yeah, go ahead.
I was just gonna ask, like, what in the full arch world, what are kind of some of the biggest mistakes that you see from providers, and what can providers do to fix those mistakes? I feel like that's there's a lot of clinical modalities, a lot of different things, and I'm just curious, kind of what you see. What can somebody listening to this take home that's going to help them in their clinical abilities?
Well, I'm going to back up before the procedure. Preparedness and education and mentorship are lacking across the board. I mean, everyone thinks that they can go out and just take like a 2-day class and then just go home and start slinging all on fours. So because I'll say that because most of what I see come in my consultation room for revisions is just like not following very basic principles. Like, did you even learn like step 1 in the first place? It's like, it's not hard. Like it's a cookbook procedure. It's a big procedure made up of 26 little tiny procedures. And you got to have the skill set for all of it. You got to have a good background. Because I think that honestly, like 95% of complications were preventable if you just did it correct in the first place. Like you said, peri-implantitis, I agree with that. Most peri-implantitis occurs because of the surgical placement, the platform of the implant and where it was at and how it was placed and where. And I think the same thing goes with, full fixed immediate load, full arch. 95% of these complications are that it wasn't done correctly in the first place. So going back and learning a stepwise approach, a methodical approach, deliberate approach to this procedure is essential. But I think you were asking probably, the number one cause of complications. It's certainly in two things really, and they're very related, I think. Understanding proper prosthetic setup and vertical dimension of occlusion, condylar centric vertical dimension of occlusion, having an understanding of that. I think that 95% of dentists, probably more, don't think about condylar centric. That's something I talk about. It's big time, especially in my module 1 and 2 classes. Understanding prescribing the proper vertical dimensions of occlusion, condylar centric. And two, the alveoloplasty that's required and the bone platform interface. Where is that? All right.
Mm-hmm.
If doctors would understand condylar centric vertical dimension of occlusion, proper alveoloplasty and platform placement, 90% of their problems would go away.
Mm.
Just those two simple concepts. That's just what comes to mind offhand. I don't know. What do you guys think?
No, I mean, I think that's solid. I mean, I think the the alveoplasty and the platform interface, I think that one's a little bit more obvious. I think that that's something that definitely gets overlooked, but it's like a very simple, conversion mentally that people can make, and it would prevent a ton of things. And also respect to the soft tissue too. I think we focus way too much on hard tissue,
Right.
forgetting that the actual nutritive thing that's really going to protect and seal off that implant is not the hard tissue at all. That's extremely important. I am curious if you wouldn't mind expounding a little bit more on condylar centric. I assume this means, this. There's so many different definitions on like centric relation, right? Like the most superior anterior position of the glenoid fossa and things like that. But like how that really turns out in the stage 0 record taking, how you're calibrating that, and maybe just one simple thing that people can do at the record taking stage to maybe account a little bit better for centric relation.
Sure. This is big in module 2, prosthetics and digital workflow. But the proper record taking, Keith Klaus, my buddy at Digital Workflow, I give a shout out to Dr. Klaus down in Mississippi. Brilliant clinician, smart guy, engineer turned dentist. But we teach digital workflow, and we see all of the errors, 95% of the errors come back in record taking.
Yeah.
Right. Are you able to, and I've narrowed it down to condylar centric vertical dimension of occlusion. Give the lab the scans at your desired vertical dimension with the condyles fully seated on both sides. Okay. Then there's some other occlusal things. I mean, I don't think we have the time to get into.
No need. Yeah.
But I coach them into that. I get them situated. We record at the vertical where that we think that condylar centric is. I go to my CBCT, and with the putty or the bites or the bite rims or whatever in place, I check to make sure that both condyles look like they're both seated and even. All right. And then you go from there. You can adjust. You can totally adjust. After I put in my first prosthetics, we go take a CBCT. I check all my implant placements, but I also take a look at the condyles. And I mean, we're not able to look at soft tissue in the dental office yet. I mean, nobody can afford an MRI, nor would we expose patients to multiple MRI radiations like 4 or 5 times in a process. We're not going to do that. But this is a good go-to way to see if the hard structures look like they're balanced. Okay.
Yeah.
Guess what? When you see that, patients' faces look relaxed. They look better.
Yeah.
And it's so hard to find. I talk about this so much in module 2, but hammer this home. It's so hard to find general public in condylar centric. People are in a best fit match, to borrow a term from my exocad days, where their teeth just kind of interdigitate.
Yeah.
And you put them in the full arch and you screw them down, and their midlines are kind of on day 1, and you look at them 6 days or 6 weeks later and they shift. Why? Because everything has relaxed. The whole stomatognathing system has relaxed. The condyles have relaxed. You basically deprogrammed them.
Yeah.
People ask me all the time, do you put people like in a COIS deprogrammer before treatment to get that? I'm like, no, I'm going to take out the teeth. They're going to get deprogrammed. Like,
that's good.
The all-on-4 procedure is a deprogramming procedure, and I design my lowers in a very specific way that I get to deprogram everybody. But you wouldn't believe probably 30% of people, 25% of people come back in 6 weeks for a wellness check with a midline shifted. And now we can go back and get condylar centric. This is one of the biggest problems I have with anybody teaching like the bulletproof zirconia in 3 days, or, we'll give you final teeth in 2 days. Like, do you even know what's going on here?
Yeah.
Like, are you a doctor? Do you know what's going on here? How many reps have you had? This is huge.
So you're taking the CBCT. So whatever you've done, let's say you haven't opened the bite and you've jigged that somehow, a putty bite,
Yep.
like a in some sort of anterior stop, whatever. You're taking a CBCT while they're locked into that and verifying the seating of both condyles, and then you're
Right.
also checking post-operatively once you deliver your temps, they're
Right.
in occlusion, they take CBCT, and you're verifying that that position is the
Yeah.
same.
100%,
Okay.
100%. And, you don't have to expose them to, too many scans. My average patient gets 3 scans,
Yeah.
usually the consult scan, my
Yeah.
record scan for condyles, and my post-surgical scan,
Okay.
just
Sure.
to verify. So most people get 3.
Yeah.
Now, if I was grossly off or the patient was uncomfortable, developed a TMD or something, acute TMD, or trismus or something, I would
Yeah.
probably be doing some more scans to look at their condyles. But
Yeah.
the true test is symptoms. So we get it close, and 99% of the time, it's great. The patient looks relaxed. They say, "I've never felt better. My headaches are gone. I didn't even know it was all related to my bite." Then that 1% of the time, it's not always true, right? You gotta let's see what looks balanced on the face, see when the patient's comfortable. Symptoms are the ultimate test.
Yeah.
Ultimate test. No symptoms, and they look and feel better.
Yeah, no, that makes a lot of sense. And in terms of symptoms, I mean, at what point, because there's going to be some overlap between post-surgical symptomology and,
Sure.
symptomology is secondary to the occlusion that you've put them in. Like, at what point are
Right.
you really paying attention to that? Once
Yeah.
you're assured that all that inflammation has gone away, and now we're just dealing with an occlusal problem.
Say that again? I'm sorry, I got
I guess
interrupted there on the
yeah,
side
no,
here.
no, you're fine, you're fine. So, like, post-operatively, a patient may
Yeah.
say, "Oh, my head is hurting," or "My muscles feel sore," or whatever's happening. How do you kinda differentiate between, what's a post-operative surgical complication or maybe them just accommodating to a new bite and having gone through surgery and things versus something
Yeah.
that's actually secondary to how their occlusion set up?
Okay, well, there's no secret about it. This is a major surgical procedure.
Yeah.
Okay. Anybody who says it's simple is just not being truthful with themselves.
Yeah.
It can take 6 weeks for the
Yeah.
base to fully like settle down.
Yeah.
Anybody who's had any surgery whatsoever, they know the body goes through a very, slow healing process. That first sigma of 4 to 6 weeks is big. Nobody
Yeah.
feels 100% normal in less than 4. I mean,
Yeah.
even if it's just like I feel funny, right?
Yeah.
So you gotta you've got, like, some growing pains to do. Um, but I'm talking about that person that you see that, like, you can tell they've got, like, trismus, they've got,
Mm,
um, some spasms, they don't look or feel good. You can tell, like, they come in and they look at you and they're like, "Everything yeah, is everything okay?" You're like, "Yeah, everything's fine." I'm like, "No, your bite's off." Like,
yeah.
you shouldn't look this stressed. When you get somebody's vertical dimension and centric in and you're making adjustments, literally they'll close down and they'll be like, "Oh my god, that feels better."
Yeah.
You know?
Yeah.
So you've got to listen to prosthetics is a huge listening game.
Mhm.
People be like, "I'm having trouble with my speech." Okay, what do you think is happening? Tell me what you think is going on.
Mm.
I know how to deal with speech. I was in speech therapy as a kid. My sister-in-law is a speech therapist. We talk about it all the time because, by the way, if you're a dentist out there doing prosthetics, take speech,
Mm.
take speech therapy education. You're gonna need it. You're gonna
Mm.
need what the tongue does on different random movements. You need to know that.
Yeah.
So, but I mean, I might already know, but I ask, what do you think's happening? You
Yeah.
know, the diagnosis oftentimes is in listening.
Mm. Yeah, no, I like that a
Okay.
lot, and that's one of those nuances that, like, I think that when people get really into, say, full mouth rehab, right? They're working with natural dentition, they're trying to open up someone's bite and reestablish a whole new smile and things like that. I mean, you have to go really deep, right? Like, you go into Coyce, you go into Dawson, different occlusal philosophies, and, like, you have to go really deep and, like, really learn the technical aspects of it, and it seems like most people that take full mouth rehab seriously, they go and do that, and they go down those continuums. But a lot of full arch people don't do that, right? Like, we do not go to we're going to Orca, we're going to Clark Damon's course, we're going to Atlantic Implant Institute, we're flying all over the world just plate, we're slinging titanium just all over the damn world, right? But like we don't go that deep into occlusal principles, and like we kind of throw a lot of that out because like, oh, we're taking out the teeth. So much of this complexity goes away. We make it simple. But in reality, those things do still exist. They do still very much matter. Perhaps it's more simplified. Perhaps we've made a less complex system, maybe. But those things still matter. And I feel like so much of the stuff that's kind of in the gray, like the problems that you just say, you know what, sometimes these things happen and patients just have to deal with it. At least they have teeth, right? I think a lot of these problems are solvable if you go that deep. And I think to really last long in this and have that sort of patient satisfaction that I'm sure you've achieved, like you do have to know those things, and they do matter.
Absolutely.
Yeah, that's probably one thing I'll be taking out of this conversation is, maybe I do need to go to like a speech program, because that's probably one of my my biggest issues with post-op complications is patients with speech issues. I do my best at after the patient comes in, if they have a speech issue, I'll go through the gambit. I'll have them, record them doing their different movements. I'll record them speaking. And I'll try to work with my lab to fix some of those issues. And usually we get it fixed, right? But sometimes it takes me 3-4 sets of teeth to get it fixed. And that's probably something I could work on is it'd be great if I could fix that in 1 or 2 sets, by just changing certain principles. But speech is a tough one. It's hard.
Yeah.
It's one that, it's not sexy, right? It's not pretty nobody wants to go to a course like that, but it is fundamental for like I would say 10, 15, 20% of the patients that come back with like a speech issue here.
There's no like badass speech course. There's no course where you go out in the desert and shoot thermite, to learn like speech pathology. I think that's the thing is like we like these like really hardcore courses where we're doing surgery and there's blood and guts everywhere. Like things that like speech therapy, they're not sexy, but man, like that's the kind of stuff that solves that 5% of problems in your practice that drive you freaking nuts.
Oh, for sure. And it's especially bad when the patient thinks they can hear it and they can't get over it and you can't hear a thing. That's when you really got to like sit down and talk about it. Because usually those are just like so small. Yeah. I mean, if you guys have worked on musicians or if you've worked on people that play like wind instruments, people that make their living talking, they make their living going around the country. I mean, you better be on point. I mean, I've worked on actors and it's,
Right.
I mean, it's a really important facet of the prosthetic is how well they can talk. So be ready for, you say like, when do you go, get into all four, or how much do you go in? You go all in because you gotta be able to handle these complications. I think that goes for any doctor whatsoever, no matter what your procedure is. If you can handle the complications, if you can address the bumps in the road, then you're ready to do it.
Yeah,
for sure.
But I think that's also kind of the tough thing about it, though, is like, when you go through, let's say, a residency, like a GPR, AGD, or surgeons, they do surgical residencies in hospitals. Like their whole job is they work in a place where complications get sent to. So the complications just come in. They didn't treat them initially, but someone else did, and now they're dealing with the complications. So it's very easy for people like that to say, "Oh, well, I know how to deal with these complications, so I have every right to be doing this." But if you didn't do something like that, if you've been learning through the world of CE, it's more difficult because there's not a lot of courses on complications that are live patient courses, right? It's very difficult to put that together, right? Oh, you're having this complication. Well, just hold on just a second because I'm trying to throw this course together, right? Like it doesn't work that well. I've seen people try to do complications courses with live patients, and it's a difficult thing to do. The ethics are questionable, right? In a way, like the complications you're going to run into are going to come from your own cases. So it's kind of this catch-22. It's like when you're out in the job market and everybody wants experience, but how are you supposed to get experience if no one's hiring, right? Like it's kind of this chicken and egg thing that happens.
We're adding a module in 2026, me and another doctor. So by the way, my institute's not just me, I've got faculty doctor as well. But my next module 6, is a complications weekend. We're going to talk about complications in singles and full arch, and that's all we're going to talk about is complications. So that's going to be in the fall of 2026. We haven't announced it yet, but that would be vital to go to. Understand, hear people like, I'm going to show you some grotesque stuff and how we managed it, how we fixed it. But no pictures, please. Anybody who says they don't have complications is probably sitting on their couch, like they're not doing anything.
Yeah,
for sure.
Well, hey Adam, I think we're coming short on time here. We usually like to do it right about here. Is there anything that we didn't go over? Is there anything that you want to talk about with the Atlantic Implant Institute that we could find out?
Yeah, what's coming up?
We've had a great time having this conversation. I would love to just make sure we hit anything that we didn't for you.
Yeah. Well, this episode brought to you by the Atlantic Implant Institute. Let me tell you what's coming up in December.
I said the Atlantic Implant Institute is now a sponsor of the Fix podcast.
Well, that's right. You're sponsoring me. Wait till you get my bill. I'm sponsoring you. You're sponsoring me. You give me your bill first.
Okay.
All right. Yeah. Double it.
Okay. In December, my buddy Juan Gonzalez is here for remote anchorage, core anchorage. We've got that 2 days plus cadavers. We're going to do, by the way, all of our classes are didactic, hands-on, live surgery observation, and usually a lab like a cadaver course. So that's in December. So you got a chance to come learn remote anchorage. In January, I'm going to start the continuum over with module 1. And I'd like to put a special shout out right now. Anybody that is looking to get into full arch, you need to come to module 1, boot camp core fundamentals. If you don't know if you want to take the continuum, just take module 1, and we see probably 3/4 of those people add on module 2 and 3 later. So January, you want to be there. My co-faculty, Dr. Athena Gadarzi from 4M Institute in Los Angeles, a good friend of mine. She's co-hosting module 1 with me. And then we've got FP1 will come back in May with Dr. Sonata, business of full arch in April as well. And then we'll have live patient experience in the fall. I do not know yet if we're going to run the continuum twice yet for 2026, only because I'm very, very busy.
Yeah. So, naturally.
Yeah. Take it now while you can. It might be your only time.
Awesome. Yeah, that's great. And I think we got to make our way out there and see all those wonderful things you got cooking. We've been following your videos and seeing all the things that you test out. And I think it'd be really awesome just to work with you in person and see how some of that goes down. So I definitely want to look at that complications course, and I promise I won't tell any stories after.
And send your docs. Your docs need training. Send your docs.
Yeah, you bet.
Yeah, awesome. For sure.
Yeah. Well, Dr. Hogan, thank you so much for coming on the Fix podcast and also for having us on your podcast. This has been a lot of fun. It's been a really easy conversation to have, and I'm sure we could have gone twice as long if we had the time. But, I just really appreciate all the experience you bring to the forefront. And thank you so much for democratizing all this knowledge and all this experience you've had to so many people that want to go out and do full arch and get themselves in trouble. Right. This is just an awesome thing that you're doing. And, I think the world needs more podcasts on fixed. It needs more podcasts on implants. We need to be talking about this stuff more, the real world, the complications come along with it, all the pitfalls and things. And I think you're doing an excellent job with that. And anything we can do to help support that, we're more than happy to do it.
Thank you very much. No, it's been a pleasure talking to you. Second time we talked, you guys are easy to chat with. I can see why you're so successful. And I can see why doctors would want to work with you too as well. My hat's off to you on the empire of offices. It's something I haven't done yet and often dreamed about, but not sure I'm ready to get into. Maybe we talk offline on that more, help each other out.
Definitely.
All right. Sounds good.
Thank you.
You have a good one. Appreciate
Peace out.
it.
Everybody